Hello, I'm Fiona Atfebwe, and welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, we start with some housekeeping. You can choose the language you would like to hear for the press conference by turning to the globe on the bottom of the Zoom application on the right and selecting your language. You will also have a chance to ask questions to our esteemed panelists. And to do this, please use the question and answer function on the Zoom application. Also, remember that you'll need to provide a name and the news agency that you represent to have your question answered.
Bonjour à tous et merci de vous être connectés pour ce point presse. Pour poser vos questions, merci d'utiliser la fonction Q&R de Zoom que vous trouverez dans la barre d'outils en bas de votre écran. Et pour l'interprétation, vous pouvez choisir la langue dans laquelle vous souhaitez entendre en utilisant le étui d'interprétation, le globe, qui est également dans la barre d'outils. Merci à tous et bonne conférence.
Merci, Francois. So joining us from Brazzaville, the Republic of Congo this morning is Dr. Richard Mihigo, the Vaccine Preventable Diseases Program Coordinator for the WHO Region Office for Africa. And right now, I'll hand over to Richard to introduce our other panelists.
Dr. Mihigo, you are muted. We cannot hear you.
Please go ahead, Dr. Mihigo.
Okay, so I was saying thank you very much, Dr. Twebwe, and good morning, colleagues, or good afternoon, depending on where you are. Thank you really for attending today's briefing, which will focus mainly on COVID-19 vaccine rollouts in Africa. I'm pleased to be joined today by Dr. Sabin Nsanzimana, the Director General of Rwanda Biomedical Center, and Professor Anthony Costello, who's a professor of Global Health and Sustainable Development, University College London. We'll be having as well Dr. George Kizebo will be joining us from Guinea, who's the WHO representative in Guinea if there is any question on Ebola. So a month ago, Africa received its first delivery of COVID-19 vaccine from the COVAX facility. This kick-started vaccinations in much of the continent. To date, we have 32 countries that are vaccinating high-risk population groups using COVAX-funded vaccine, as well as vaccine received through bilateral deals or donation. Early lessons from the ongoing COVID-19 vaccination show that Africa's experience in mass vaccination campaigns and robust preparedness and rollout have helped some countries reach a large proportion of the target population. Rwanda has vaccinated more than 345,000 people. Dr. Nsanzimana will speak more about the progress Rwanda has made. In Ghana, over 470,000 people were vaccinated in the first 20 days of receiving doses. While in Angola, more than half of those vaccinated are healthcare workers. So far in Africa, close to 7.7 million vaccine doses have been administered. This is indeed a good start, even if the continent has received only limited doses and much later than other regions of the world. The momentum that have started must be kept up to widen the scope of COVID-19 vaccination beyond the high-risk group that have been prioritized by many countries. For this to be achieved, it is important to make vaccine equity a reality. Professor Costello will speak more about fair access to vaccines. We are concerned that while COVAX delivery have enabled many African countries to roll out vaccinations, the slowing pace of vaccine supply that we are now seeing risk widening the gap between the world's vaccinated and the unvaccinated populations. Vaccines have yet to arrive in 11 African countries, and we're glad to hear this morning that South Sudan received its COVAX delivery, which at least we are remaining with 10 countries, which is too much. We acknowledge the global challenges for manufacturers to suddenly have to meet the demand for billions of doses. The world usually produces around 3 to 5 billion doses annually. Now with COVID-19, the pressure is huge. This quantity is now being required to increase 3 to 5-fold. However, it is unfair, I believe, that some high-income countries are looking to vaccinate their entire populations, while others, and particularly including most in our region, are struggling to reach a significant proportion of at-risk population. So through the COVAX facility, we are exploring ways of increasing vaccine equity. One possible solution is by collaborating with high-income countries that have surplus vaccine stocks to share their doses. Another is to promote technology transfer and reduce intellectual property barriers. We are also working with partner organizations and member states to strengthening local vaccine production in Africa. WHO is also encouraging collaboration with the private sector to help procure and distribute COVID-19 vaccine, such as the initiative by the South African telecom firm, MTN, that has delivered over 720,000 doses to 9 African countries. This is something we need to comment. Vaccines definitely remain our surest way of beating this pandemic. Now in Africa, COVID-19 cumulative case fatality rate stand at around 2.7%, which is a little bit higher than the global rate of 2.2%. A decline in the pandemic's trajectory seen since January has now plateaued, and we are concerned of the increased number of cases in few countries. More than 4 million cases has now been recorded in the continent, and over 110,000 lives lost to the virus. So large-scale vaccination campaigns cannot begin soon enough. So I'd like to thank you for joining us today, and I look forward to our conversation. Thank you, Fiona.
Thank you very much, Dr. Mihigo. Dr. Sanzimana, we've had very good things from Rwanda. Could you now tell us about how Rwanda has managed to roll out the COVID-19 vaccine to high priority groups?
Thank you very much. Good morning, good afternoon, everyone. It's a great pleasure for Rwanda to join this conversation on vaccine in Africa. And I'm pleased to be with my colleagues, Professor Castello, Dr. Richard, and Dr. Kizerbo, and everyone who is following us from remote in many ways. So the experience of Rwanda on vaccine deployment, I would say that didn't start on COVID vaccine because we've been building our national vaccination program on other diseases. And when COVID vaccine was made available just a few days ago, we didn't want to create a parallel or something new, actually, because we already had a program that was built from national level up to the community levels. So we just plugged into the existing system, and it was quite easier and faster to make it happen, because although this vaccine has some specialty, because we had the opportunity to receive the Eritrea called requiring storage vaccine just on March 3rd. The same day, actually, we received the first doses of vaccines in Rwanda. So we had also built this additional capacity to store these vaccines that require some special conditions to store. And we had received the Ebola virus disease vaccines 2 years earlier, and with the same conditions. So it was a kind of practice, and it was quite easy to roll out this, and having teams in charge already trained, both at central level and provincial and up to the community. So working multi-sectorally in Rwanda has helped. We've been doing a lot of exercise and preparations just to see when the vaccine lands at the airport. We don't want to keep it additional hours if we can deploy it immediately. And this is what happened on March 3rd. we received the first batch of the vaccines in the morning and the second batch in the afternoon. And the same day, we had invited all the district hospitals to be on standby at the warehouse, and we already started packing the vaccines the same day. And in the morning, they were all deployed in all districts. And the health centers also picked the vaccines in the same day, just 24 hours after, to the community. So on 2 days, within 2 days after the vaccines landed in Rwanda, we had already vaccinating massively in the whole country, and it went so fast. And today we have actually finished all the doses we had received between the 3rd and the 5th of March. And what we're doing now is to what Dr. Richard was talking about. How can we get more vaccines in an equity manner, in a way that we don't start something and accelerate and stop at some point. So this is the situation now. We've learned a lot of lessons. We didn't create a new program, as I said. It was something existing. We had teams that are capable, that are trained. And the thing is that deploying a vaccine rapidly without waiting is the best way you can battle this virus, is the best way you can actually stop the progression of this virus. We were lucky to be in a situation where we didn't deploy a vaccine in a firefighting mode when you're already containing the virus, the spread of the virus. 2 months before, we had a kind of a second wave, in particular in the capital, Kigali. But the vaccines arrived just when we were coming out from a lockdown at the capital of Kigali, and the cases went really down, and it was a kind of an opportunity for us to deploy the vaccine where we're not distracted by other prevention measures. So additional to what we're doing, the vaccine was coming as a tool to bring more pressure to this virus. And we look forward to get more vaccines. There's a lot of work happening now to access the doses. But in terms of deployment, in terms of data follow-up and advanced events management, we also had a lot in place, and we are happy that the vaccine has been deployed in a safer manner. The follow-up of everyone who had received the first shot is going well. We don't have complication or incidents or whatever, as you can imagine, but it actually is happening very smoothly. The only challenge is we need just doses and make it happen and continue to reach our target, which is 6% of our population vaccinated by next year. But if we can bring it now, we can do it now, why not achieving it in the next couple of months? So briefly, this is experience of Rwanda. We look forward to hear from other colleagues how it's happening, and I'm happy to take some questions, our experiences as we move on these discussions. Thank you so much for having us. Happy to continue.
Thank you very much, Dr. Sanzimana, and really that's very exciting, and thank you always for accepting to share your experiences from Rwanda. So now over to you, Professor Costello. Do you think more can be done to ensure Africa continues to get a steady supply of the much needed COVID-19 vaccines?
Yes, absolutely. Much more must be done because we're all in this together. This is a global pandemic, and we need to solve it through global vaccination and global public health methods. Thank you so much for inviting me to this. I'm seeing some old friends having been a director at WHO of maternal, child and adolescent health a few years back. I think if we start with the UK, I mean, at the moment, you know, on the news, there are big fights going on across Europe to argue about who gets vaccines and when. And when you look at the map of the world, you know, Britain's doing a little bit better on vaccine than other places alongside the USA and Israel and the UAE. But we've had a terrible death toll. I mean, we in Britain are approaching 148,000 deaths. And I think it was Dr. Kizerbo who just said that there've been a total of 110,000 deaths in Africa. So Britain has not done well. It's done well on getting the vaccines out, but it's done very badly on public health. And I was involved in setting up an independent scientific advisory group of experts to advise the government on different strategies to what they were doing. But I won't go into that now. I think the challenge for Africa is firstly to get access to vaccines. And as we've seen, there's a global scramble at the moment for relatively scarce vaccine supplies. Then you've got the logistics challenge, which I'm more confident about. You know, if you're going to reach a 60% target of vaccinating the continent by the middle of next year, which I think is the aim, then in this year, if you want to reach 35% of the African population, you're going to need 800 million doses. I'll just come on to that in a moment. But the third challenge, of course, is mutations, SARS-CoV-2 mutations, because you are heavily dependent upon the AstraZeneca vaccine, which is the lowest cost, because the original deal between Oxford University and AstraZeneca was that this would be a no-cost vaccine, a no-profit vaccine, unlike, you know, Pfizer and Moderna and others. And so it's a problem because you depend upon that, and it seems from the evidence that Southern Africa, where there's a lot of resistance to this vaccine with the new and emerging South African variants, means that we may need to modify that vaccine and introduce later new versions of the vaccine. So these are big challenges. You know, there are, let's say the population of Africa is 1.2 billion. You're probably going to need to vaccinate 750 million people by the middle of next year. That's going to mean you'll need almost 1.5 billion doses. So that's a huge challenge. I'm pretty confident that you can get there, because I think the immunization infrastructure in Africa generally is not bad. I mean, the figures have come up dramatically over the past 10 or 15 years. So I'm confident. I think your public health structure is often better than Europe, to be honest. But having said all of that, at the moment, you're going to need at least 120 million doses if you're going to achieve this 60% target by June of this year. And I was very pleased to see that you've set up your own, it's called AVACTA, isn't it? The African Vaccine Acquisition Task Force, I think, something like that. And that's really important, alongside the fact that you do have genomic centers around Africa that can now do a lot of the genomic sequencing. And you do have vaccine production capacity across the continent, although at present that's not geared to COVID production. So I think there are a lot of issues that need to be addressed. Certainly, I and my group in the UK are very keen now to focus more on the global challenge, the need for finance and vaccine to be made available around the world. You know, Britain has just had Brexit and separated from the European Union. And that means we need to be trading with other continents. And I know that our Prime Minister has made a big thing about trading much more with Africa. If that's the case, we need to have exchanges, and we need therefore to have uniform vaccination. So there is an economic imperative that we all are in this together. And I hope, although you've made a slow start, you have actually had a much lower burden of disease than many other parts of the world. I hope that with pressure and with self-organization, which I see happening across the continent, I think you can achieve that target by the middle of next year. And hopefully we can even bring it further forward. I'll stop there.
Thanks, Professor Costello. Thanks for distilling all this information for us and the ray of hope that and reassurance and confidence you've instilled. So now, on a slightly different topic, you heard that we have Dr. George Kizebo, the WHO representative in Guinea, who will tell us about an important milestone right there in Guinea. Over to you, Dr. Kizebo.
Thank you, Fiona. Glad to be in the panel with Professor Costello, Dr. Miigo, Dr. Sebin, and the press listening to us. So today, 25 March, we are starting a 42 days countdown to declaring the end of the Guinea Ebola outbreak. The last Ebola confirmed case has recovered and was discharged after testing negative twice for Ebola, and no new cases have been reported since the 4th of March. This comes after a few days of the countdown beginning in the Democratic Republic of the Congo in North Kivu, where there is also an ongoing Ebola outbreak. These are very good news. It seems that both Ebola outbreaks in DRC and Guinea are slowing down and could be going towards the finish line. However, we must keep our foot on the pedal and continue to intensify key response measures. We must keep up our efforts on surveillance, vaccination of high-risk groups, and community engagement. To really ensure the outbreak is under control, public engagement must be strengthened as community hesitancy remains a persistent challenge in some pockets. For instance, WHO is setting up a committee that will comprise 6 influential members of the community, religious leaders, traditional healers, youth, taxi motos, and others to help overcome resistance within the community in Nzerekore region in Guinea. WHO also urges the international community to fund a 3-month-long $25 million response plan for Guinea and high-risk neighboring countries, Liberia, Sierra Leone, Cote d'Ivoire, and other neighboring countries. This will help responders maintain the progress made in containing the ongoing outbreak and ramp up key health measures. The funding is also critical for service continuity, early recovery, and to improve preparedness for outbreaks in Guinea and in neighboring countries in line with the international health regulations requirement. In order to tackle preparedness, tomorrow there is a high-level meeting on resilience and response to Ebola, which will focus on increasing international coordination and securing funding and other commitments to address Ebola outbreak. This will happen tomorrow. It will be co-hosted by WHO, Africa Centers for Disease Control, the West African Health Organization, as well as governments of the Democratic Republic of Congo and Republic of Guinea and the United States. So we are really at a critical milestone in our response, but we need to really strengthen surveillance and make sure that the countdown will be supported by robust public health measures so that when we say it's over, we are really confident. Thank you very much.
Thank you, Dr. Kizebo. That is very exciting news, the fastest that we've seen, and indeed we now believe that vaccines actually do work. And now that we've heard from all our panelists, it's your turn to ask questions. And remember to do this, please use the question and answer function on the Zoom application. Also remember to tell us your name and the name of the news agency that you are here to represent. But also if you want to go live, remember we can give you an option to go live. And for that matter, I will now go to you, Hadiatu Barry from Guinea TV, to go live with your question.
Alors, bonjour. Alors, je suis Hadia Toubari de la République de Guinée. Je travaille à la télévision nationale. Ma première question s'adresse justement au premier panéliste. Par rapport au programme COVAX, est-ce que l'OMS compte envoyer des vaccins, des doses vaccinales de AstraZeneca en Afrique? Si oui, quelle est la réaction des pays africains qui vont obtenir ce vaccin? Puisqu'on sait aujourd'hui de plus en plus des pays européens, il y a ce qu'on appelle des effets secondaires du vaccin. Est-ce qu'il y a des pays africains aujourd'hui qui ont reçu ces AstraZeneca et quelle est la réaction des populations? L'autre question, c'est justement par rapport avec Dr Kizerbo, qui est le représentant de l'OMS dans mon pays. Et justement, il y a eu une résurgence de la maladie virus Ebola dans le pays. Et aujourd'hui, nous avons quand même une note d'espoir parce que de plus en plus, on n'a plus de cas. Et le dernier cas, comme il a dit, il est sorti guéri. Justement, qu'est-ce qui garantit aujourd'hui que la Guinée ne va pas avoir un autre cas de contamination de la maladie à virus Ebola? Mais d'autre part aussi, c'est la question qui se porte sur l'origine de cette nouvelle résurgence. Merci.
Okay, over to you, Dr. Richard, for the first question, and Dr. Kizerbo will respond to the next.
Okay, thank you, Dr. Fiona. Maybe since the question was asked in French, let me respond to our colleague in Guinea in French as well. Merci beaucoup pour cette question. Vous avez demandé combien de pays l'OMS compte envoyer le vaccin AstraZeneca en Afrique. Je voudrais ici d'abord préciser que le vaccin AstraZeneca est un vaccin qui est pour le moment distribué à travers le dispositif COVAX sur de nombreux pays dans la région africaine. À la date d'aujourd'hui, nous avons déjà autour de 32 pays qui ont déjà reçu ce vaccin, soit à travers l'initiative COVAX ou à travers des discussions bilatérales ou des donations pays par pays. Donc, c'est un vaccin qui est largement utilisé. Alors, quand vous parlez de la réaction des pays par rapport aux événements que nous avons suivis il y a de cela quelques jours sur les possibles effets secondaires, je voudrais ici préciser que l'Organisation mondiale de la santé, à travers le groupe consultatif mondial sur la sécurité de vaccins, s'est réuni la semaine passée et a examiné toutes les données en rapport avec la sécurité, mais également l'innocuité de ce vaccin, et est arrivé à la conclusion que ce vaccin reste un vaccin sain et que le bénéfice pour l'administrer est de loin supérieur à un éventuel risque. La même conclusion a été faite par l'Agence européenne des médicaments, qui a également analysé les données des cas secondaires qui étaient rapportés et n'a trouvé aucun lien entre l'administration du vaccin et ces cas secondaires. Donc, nous avons deux organisations importantes qui ont fait de communiquer, de réassurer la communauté internationale. Et la position de l'OMS a toujours été la même. Nous recommandons et nous continuons à recommander aux pays d'utiliser ce vaccin. Donc, au niveau des pays maintenant africains, nous n'avons pas vu des problèmes majeurs. C'est vrai qu'il y a eu un ou deux pays qui avaient mis en pause l'introduction de ce vaccin. Mais depuis la déclaration de l'OMS et de l'Agence européenne des médicaments, ces pays ont pour le moment considéré la reprise de la vaccination. Donc, toutes les précautions ont été prises et les inquiétudes dissipées. Je voudrais encore une fois ici, comme l'a réitéré à plusieurs reprises la directrice régionale de l'OMS pour l'Afrique, dire que ce vaccin était un vaccin sain et que nous appelons la communauté et les populations africaines à se faire protéger avec ce vaccin.
Thank you, Dr. Mihigo. Dr. Kizerbo?
Thank you. I think I will also respond in French. In terms of the question from our colleague from Guinée. Je voudrais juste reconnaître avec vous que c'est une vraie note d'espoir que cette situation que nous vivons actuellement avec 0 cas confirmé et insister encore sur le fait que ceci ne nous prémunit pas du risque de résurgence, comme vous l'avez dit. Le risque zéro n'existe pas, c'est connu en santé publique comme dans les autres domaines, et c'est pourquoi la préparation, la détection précoce et les capacités de riposte sont aussi importantes dans les pays en lien avec le règlement sanitaire international que l'OMS promeut et qui est donc un engagement contraignant pour les États membres. Je voudrais parler de l'origine de la résurgence actuelle. Les hypothèses sont en gros celles d'une résurgence à partir d'un réservoir humain qui aurait persisté dans la région, étant donné que les données de séquençage par 3 laboratoires, et il faut saluer le fait que ce sont des laboratoires pour la plupart basés en Guinée, mais aussi l'Institut Pasteur de Dakar, ont montré une proximité génétique très grande entre le virus actuel et le virus précédent de 2014 à 2016. Donc, on pense qu'il serait possible qu'un réservoir humain puisse exister, en plus de la transmission zoonotique qui était classiquement reconnue pour Ebola. Cela change un peu le paradigme de comment nous allons approcher les prochaines résurgences en utilisant des innovations comme la vaccination et aussi la prophylaxie chez les survivants et chez leurs contacts. Donc, c'est une nouvelle ère qui s'ouvre avec beaucoup d'éléments d'innovation qui pourront permettre d'être mieux préparés en lien avec les plans nationaux de sécurité sanitaire et le règlement sanitaire international. Je voudrais confirmer pour la COVAX que la Guinée est signataire de COVAX et s'apprête à recevoir un lot de vaccins après l'accord du comité interministériel du conseil scientifique et du ministère de la Santé. Merci.
Thank you, Dr. Kizebo. Dear journalists, I would like to remind you that we do have a huge number of questions and we'll only be able to answer one question. So remember to prioritize your questions so that we can give as many people a chance to ask their questions. The next question is from Saul Butera, Bloomberg's correspondent in Rwanda, and it goes to you, Dr. Nsanzimana. And it says, Rwanda seems to be ahead of other African countries in vaccinating people. What is Rwanda doing better? And when do you expect the next batch of doses? From which manufacturers and the numbers expected? Over to you, Dr. Nsanzimana.
Thank you very much for the good question and reflection. I think, as has been highlighted by previous speakers, the biggest challenge now in this campaign vaccination is access to enough doses that are needed and on time. So as I said before, all the doses we received both on AstraZeneca and Pfizer vaccines have been utilized here in Rwanda. And we are expecting next doses, but we don't know exactly which date and time, but we hope it will be very soon. And since we continue to hope and vaccinate the people that are in need, we can only continue this partnership where the vaccine is coming and how the vaccine arrives here. So there's nothing special in what has been a plan for us, because as I said, the only principle was that we don't want to keep this vaccine in the warehouse, in the fridges. We need to have the vaccine in people's arms as soon as possible. And because these vaccines are safe, when the people are in need, the acceptability has been really high. It was not a challenge for us to finish all the doses we had within just 20 days. All the doses have been utilized, starting with the most at risk frontliners, healthcare workers. So to the question on when the next doses are arriving here, I just hope that could be very soon, but I know we are working with our different partners in many fronts that this could be as soon as possible.
Oh, thank you once again. So now next question, I'll send it to you, Professor Costello and Dr. Mihigo, to also make comments. So it's from Sarah Newe from Telegraph Global Health. And she's asking that the Lancet has published a study confirming Africa's second wave was more severe than the first by the end of 2020. What is your perspective on why this happened? What can be learned from this? And what is the exit plan for African countries to end this pandemic? I will go straight to you, Professor Costa.
Whoops. Thank you very much. It's, I mean, at the moment, the situation with spread of variants in Africa, as I understand it, is that in the north of Africa, the northern states generally have the variant of concern called the British variant, which was first reported in the UK in, I think it was about October last year. And that's the B117, and that's certainly been found in Nigeria and many other in the North African states. And there are quite a lot of states that haven't actually looked for it, but it's probably there. So that's a much more transmissible variant. The greater concern perhaps is that there are 16 countries reporting B117. The more resistant variant, the B1351, is in 17 countries, mainly in Southern Africa, and 8 countries in Africa are reporting both. This is figures I've taken from the Africa Center for Disease Control. And the worry is that because you're so dependent upon AstraZeneca, I mean, in the southern states, they are using the Johnson & Johnson vaccine, particularly in South Africa. But, you know, most of the acquisition is coming from AstraZeneca, presumably because of price. So one is going to expect it's quite difficult to predict what's going to happen. You've got a more transmissible virus, so you would expect there to be a surge, as there was in Britain and is now happening across Europe. And then, of course, you may have resistance or relative resistance to the vaccine in the southern states, meaning that you need to have a different vaccine policy, or the AstraZeneca vaccine will have to be tweaked in the coming months. So it's quite a difficult pattern to predict, but maybe some of my colleagues on the panel will have more up-to-date country-based data.
Thank you. Your comments, Dr. Mihigo?
Yeah, maybe just to complement what Professor Costello said. Indeed, the second wave was, as we know, fast and of a great intensity, and I think there's no doubt about that. But we need to understand that there was a combination of factors that led to that situation. Remember that most of the countries in the region experienced that second wave around the end of the year season. And when we looked at the data that we have, mainly the southern part of the region and the northern part were the two regions that were very much affected. And when we looked at the movement circulation around the end of year festive season, and I think all the ingredients were in place to have an explosive situation with many people traveling from South Africa to the neighboring countries and etc. There was a second important factor that was the advent of this new variant, the B1351, first discovered in South Africa, that has proven to be more transmissible, as we have seen. But the good news out of this is that the public health measure and the social protection measure that we put in place do work. They are continuing to work. We saw the situation in South Africa that after even a very, very big outbreak as a second wave, when the country put in place a strict measure, they brought down the curve quite easily. Not easily, but at least rapidly compared to the first wave. We've just heard from Dr. Sabin from Rwanda that around the same period, the country also went through a sort of an outbreak, mainly in the capital city, and they were able to control that with public health measure. So it's true that the combination of public health measure and vaccination will probably help moving forward the region to get out of this situation. But we need absolutely to get the vaccine, as we have heard from Rwanda. We need to expand the reach of the vaccination, not only to a high priority group, but also to other parts of the population so that at least many people can be covered at once. So it's only the combination of these different factors that definitely will bring us at least to a minimum return for the life before this pandemic.
Oh, thank you, Dr. Mihigo. So we have our next question from Kevin Brandt, and talking of South Africa. Richard, this comes to you, and it's still from South Africa, about South Africa. So Kevin is from Eyewitness News in South Africa, and he's asking which 11 countries on the continent are still to receive the COVID-19 vaccines. Are discussions underway with the South African government in particular to roll out vaccines to the country through the COVAX facility?
Yes, thank you, Fiona. So we, as I said in my introductory remarks, I think we had 11 countries as of yesterday that had not yet started receiving any vaccine. This morning we had South Sudan that's fortunately received its first installment of COVAX vaccine. So the remaining others, things are moving as well in that direction, but we do have countries like Madagascar, Burundi, Eritrea, Central African Republic, Tanzania, Cameroon, Chad, Zambia, and Burkina Faso. So these are the countries really that are remaining. Mauritania as well received the vaccine through the MTN donation and the Harvard platform. So we do remain with 10 countries where situation is not yet clear. Now, with regards to South Africa receiving vaccine through COVAX, yes, I think South Africa is an important member of the COVAX facility. The Minister of Health, Honorable Kize, is also the co-chair of the ACT Accelerator Principal meeting. So South Africa takes an important role in COVAX. And as we will expand, indeed, the portfolio of vaccine within COVAX, there is no doubt that South Africa will continue to get access to vaccine through that mechanism as well.
Okay, thank you, Richard. So now the next question goes to you, Dr. Sanzimana. And this comes from Hudson Kutesa from the New Times in Rwanda. And he says, with the coming of vaccines, hasn't Rwanda kind of slowed down on the treatment efforts? For example, at some point, there were plans to introduce monoclonal antibodies treatment. What happened to this?
Thank you. This is a good question from Hudson. We are not actually slowing down the other measures. Dr. Richard has mentioned it. You can't suppress one measure with the other. It's a combination. It has actually to be emphasized that with the introduction of vaccines, actually measures need to be intensified and people need to be told that the vaccine is not coming to replace masks immediately. It's not coming to replace social distance and everything that we've been doing before. The treatment as well. So regarding treatment options, I think we're getting more and more options. Monoclonal antibodies are one of the treatment options that are now becoming more and more available, although there are still some issues to get enough of these options, but enough evidence that are showing this could be helpful. And I want to emphasize that treatment of COVID-19, the best is to prevent and also treating earlier before our patient go into cytokine storm, which is a phase where even this treatment we are talking about will not be helping people a lot. We've seen in our data and also in data from other countries that prevent and treat early so that you don't go into ventilation and the other treatment that will not probably save more lives. Since I still have a minute, I want to emphasize on this issue of variants from a place on another. So basically, the virus can mutate and replicate and change itself. It doesn't need to come from a specific country. It doesn't need to come from a specific region of the continent or the globe. So each time you allow the virus to replicate and to spread massively, will always have chance to change itself and to mutate and to bring even more mutations that you don't call South Africa or UK or Brazil. It can be a mutation that is somewhere undetected. So that's why, from the public health perspective, from epidemiological perspective, you need to not allow any time this virus to get a chance to replicate, because once it replicates, it means mutations will be allowed to happen. Thank you.
Thank you very much, Dr. Nsanzimana. So now I'll go to you, Lisa Lane, to go live with your question.
Yes, hello. Thank you very much. This is for Dr. Kizerba. I'd like to first congratulate you on your ability to having gotten on top of this terrible disease so very quickly. And I'd like you to elaborate upon how you managed to do this. Does it have to do with a combination of new tools being available, such as vaccines and therapeutics, and also less mistrust between the communities and the health workers? And then two very quickly things. How many cases and how many deaths do you have, and how much money do you need in order to continue to monitor this situation and see that it doesn't resurge again? Thank you.
To you, Dr. Kizerba.
Thank you. I think this is really a collective effort from within WHO, but also with all the partners and in line with the national response plan and also the neighboring countries' preparedness plans. There was a high-level meeting of ministers of health 2 March 2021 to really come together and fight this resurgence in Guinea together. And also we have been receiving full support from the regional office and the headquarters of WHO, members of the Goan coalition. So as you said, the rapid response was critical because the next day after the declaration of the outbreak, already teams were on the ground for the initial investigation. The rapid risk assessment was done in 42 to 72 hours. And then the grading of the event was also done very quickly. So we really followed the standard operating procedures from the WHO emergency program. And this is in line with the international health regulations. Then there was engagement in line with the health authorities and the government of Guinea. As you said, lessons learned from the past epidemics were also utilized so that this time we were able to avoid some of the mistakes. And we relied on a team of very experienced responders who were trained and got their skills from Guinea and Liberia, Sierra Leone in the last epidemic, but also from DRC, where 3 consecutive epidemics were fought by young health workers, including many of them were Guineans who experimented the vaccine here in Guinea and utilized it in the DRC epidemic. So these staff members are back and are being used. There are 116 responders on the ground, 90 of which are Guineans. So we really rely on the Guinean expertise and leadership in this response. The innovations were also critical. 10 days after the declaration of the outbreak, vaccination was started, preceded by strong community engagement. Actually, the Minister of Health himself and a team of high-level responsibles of the government and civil society were deployed in the region of Nzerekore to engage the community together with WHO, UNICEF, and other partners to explain the rationale for this campaign. And so far, the acceptance of the vaccination is good, except in a few areas where we are continuing to engage. In terms of the numbers, we have a total of 18 cases reported since the beginning of the outbreak, including 14 confirmed cases. 9 of these 18 cases were recovered, and we had 5 deaths in confirmed cases and 4 deaths in probable cases. So the case fatality rate is 50%, which is still high, but I think the new treatments were important in reducing the case fatality rate, which was close to 2/3 of the cases in the last epidemic. In terms of funding, there is the Strategic Preparedness and Response Plan, which has been published. It was done at a previous press briefing, I think 2 weeks ago. This plan addresses the needs in Guinea, but also in the neighboring countries. It has been costed at $25.2 million US, and we are continuing to engage partners and leaders around this plan, which will be critical, not only in containing the current outbreak, but also in preventing new resurgence or limiting the risks in terms of health security in the region. So there is a high-level event tomorrow with the African Union, Africa CDC, the government of the US, DRC, Guinea, and WHO to look into these critical funding needs and strategic approach around the strategic response plan for the region. Thank you.
Thank you, Dr. Kizebo. We are actually running out of time, and we do have a multitude of questions still with us. Dr. Mihigo, I'll ask you 2 questions that ago, and one is from Lohans Caramel from Lamont, and he asked, do you confirm that DRC resumed vaccination with AstraZeneca? And the second one is from Omar Mohammed from Reuters. And the question is about the report about Serum Institute's decision to delay AstraZeneca deliveries outside India and what implications this has for Africa.
Yeah, thank you, Fiona. For the first question, DRC has not yet resumed the vaccination, but we are in a discussion with the government, and I think everything is going in the direction that the vaccination will start soon. There is a very interesting, for instance, discussion that is ongoing for the moment on exchange of experience between DRC and other countries. We are supporting, for instance, on Saturday, a discussion between DRC and Cote d'Ivoire to exchange their own experience. So I think the prospect looks very good, and we are yet to receive the date by which the vaccination are indeed going to get started. Now, with regards to the second point, in terms of the situation with the Serum Institute of India, this is a very complex situation, as we have seen. Of course, putting a additional pressure on the very constrained supply situation globally. There is a lot of discussion going on currently at high level between the leadership of WHO, but also Gavi, to discuss with the government of India. What is for sure, the Serum Institute of India has pledged really alongside supplying India to continue to prioritize the COVAX multilateral solution. And I think that's something very, very reassuring. And now we are seeing a lot of engagement and discussion with the government of India to make sure that the delivery for the COVAX can resume as, at least those who were planned for March and April can resume as soon as possible. So this is a place where we're watching quite very carefully, and there is a lot of discussion in the background going on, and we hope that a quick solution will be found on this situation.
Great, thank you, Dr. Mihigo. So the next question goes to you, Dr. Nsanzimana, and it's from Esther Nakazi from SciDev.net. And she says, is Rwanda allowing the private sector to participate in the vaccine rollout? How easy was it for Rwanda to roll out the Pfizer vaccine given the cold chain requirements?
Thank you. So the issue of Pfizer vaccine deployment or management, as I said earlier, was not a big challenge, as we already have been managing similar kind of vaccines. Although, of course, it's not something that would want to do when you don't have these ultra cold freezers, and also making sure once you bring these vaccines out of the deep freezers within the next 5 days, you're able to utilize them. And then if not, you're able to manage these short timelines in remote areas. But this is something we were able to manage. And we currently have a capacity to store up to 1.5 million doses of this ultra cold requiring storage conditions of vaccines. But it's manageable, and it's a good experience we learned. And we look forward to share more details on this experience if time allows, as Dr. Richard was talking about. It's always good to learn this experience from your neighbor, from someone you share the same kind of health conditions and infrastructure. Secondly, on the involvement of private sector in COVID vaccine deployment is critical. We had to actually do this in many fronts, from the planning level, from the deployment levels, and also from the access levels. So we have, for example, the city of Kigali. 60% of people in the city of Kigali attend private health facilities. There is no way you can reach these people without working with private health facilities that most of the people actually attend for many other health reasons. So we use these facilities with an agreement with the National Vaccination Program that they are providing this service not for a cost, but for also their contribution to this response. And it was easy to approach them that way. Actually, these clinics were quite happy that they are participating in this exciting moment of delivering this additional care and tool to their usual clients or patients, if I can put it in that way. So on the access side, we vaccinated, for example, doctors and nurses in public and private health facilities. And we didn't distinguish actually the people who are resident or local people, everyone who was in country being, regardless of nationality, if you're in a category of the people who had to get the vaccines, if you're a doctor, visiting doctor or resident, we are treated the same way like a doctor who was born here and working here. So because the disease, the virus will not actually distinguish this kind of categorization. The same way private and public was being addressed. Thank you.
Very interesting. We are at the top of the hour, but we shall slightly go over time. I hope you can allow us, our panelists, because we still have very many questions coming in, and would like to give the journalists a chance to get their answers. We will not be able to answer all of them, but we shall do the best that we can. So back to you, Dr. Mihigo, and this is from Laura Lopez Gonzalez from Spotlight Mail and Guardian, South Africa. And she asks, in how many countries is the variant of concern first discovered in South Africa present? And has it become the dominant strain in any of these countries? What is being done to monitor the possible rise of the variant amidst the AstraZeneca rollout of citizens in host countries?
Yeah, thank you, Fiona. And to go quickly to this question, yeah, I think we have put in place a system to support country to conduct this genomic surveillance across the region. And so far, the data that we are receiving shows us that at least 15 countries have reported the presence of these variants of concern in their countries. Now, on the issue of in which country this has become a dominant strain, and again, this is a very interesting but a very difficult question. Few countries indeed where the variant was first reported, particularly in the southern part of the region, have become pretty much, the new variant have become pretty much the dominant strain circulating. That is the case in South Africa in particular, but also in many other countries surrounding South Africa. So we think that it's very important that the surveillance system be put in place to not only ascertain the level of circulation of these new variants, but also to make sure that the extent to which it's replacing the normal strains or the old strains is there. But the issue here should, and I would like to insist on that, and I believe Dr. Sabin touched upon that. The issue it's to make sure that all the measures that were proven really effective in preventing the transmission should continue to be done. And then secondly, and we have been consistent in WHO by saying this, by increasing the vaccination capacity, we will put less pressure on the virus and avoid its mutation, as we have heard. So this is the only solution that we can have to get out of this situation.
Excellent. Then we have our second last question, and this will go to you, Professor Costello, and it's from Yusuf Ba from Al Jazeera. And he says, a lot of young women in my country are afraid of taking the COVID vaccine, fearing that it might stop them from getting pregnant. Can you please explain if the vaccine can prevent women from getting pregnant?
I know of no evidence that any of the vaccines have any impact on fertility whatsoever. It's interesting that fertility always comes up with almost every vaccine campaign, with polio, with everyone else. What I would say is that pregnant women are more vulnerable if they become infected. We know from studies in Sweden and in America that many more women, I think the risk was between 6 and 8 times, women who became infected during pregnancy would end up in intensive care unit. Now, in fact, because they're young and fit, the death rate was not very high in either Sweden or America, but they were certainly sick and ill. The impact on newborn babies is less clear, but it seems that most newborn babies escape without any problems. But, so the message should go out, these are safe vaccines. And although you get scares like we've had a big scare in Europe over, clotting and the like, which actually has turned out to be, I think, overhyped. The brutal reality is that getting this infection is way more dangerous to people than any tiny risk associated with the vaccine. And I think we need to get that message out, because when you get scare stories or misinterpretation in the media of small studies, this can create vaccine hesitancy. So I think it is immensely important that we get the message across. These vaccines are not only very effective, and I may say, even in Southern Africa, where you've got this variant where AstraZeneca vaccine probably doesn't prevent very much against mild to moderate disease, we don't know yet whether it prevents more severe disease, and it probably does, because it's highly effective at preventing severe disease in all other settings. So we need to get that balance right. Yeah, pregnancy, fertility, no evidence that I know of, unless anyone else on the panel knows, and we should emphasize that.
Thank you very much for that emphasis. And now we go to you, Dr. Mihigo, with a question from Sarah Jeving with DEVEX. Do you think embassies should bring in vaccines for their workers? Or is that problematic in terms of equity if foreign nationals get access to vaccines before higher risk groups of citizens in host countries?
Well, I think this is a very important question. Let me start by the general recommendation, and we've heard Dr. Sabin with the experience in Rwanda. I think the recommendation really for WHO and really many other countries being that for all the nationals, I think where vaccinations take place, they should be prioritized within the national plan, being national for that particular country or foreigners who are in that particular country for a particular reason, including diplomats. And in general, what we have seen in many countries, foreign diplomats have been prioritized if they fit the priority group that has been set up by the government, which is, which is indeed a very, very good thing. Now, the overall goal is to make sure that everybody, and particularly those who are at most risk, be prioritized and get vaccination at the same time as a first group. Now, in a situation where some embassies try to also protect their citizen, which it's not necessarily a bad thing. I think we just need to make sure that we strike the balance by which this should not necessarily be seen as something national or local people could take differently. And this is why, by the way, we are doing all the efforts to make sure that all the countries can get the vaccines as soon as possible. And in those countries that have not yet received the vaccine, and I think it might be understandable if some of the foreign missions or embassies tried to protect their citizens if they are in a situation where there is wide circulation of the virus. But again, to conclude on that topic, I think we believe that the solution is we are in this all together. And the more we are going to protect first the at-risk group, being nationals or foreigners, I think the better. And I think that should be our priority. And we are calling even for high-income countries that have got vaccine to share their vaccines. And I've made it very clear in my opening remarks.
Thank you, Dr. Mihigo. Today has been one of those days that really are overshadowed with questions, but nonetheless, we still have to bring this to an end. And as we end now, I'll request to our three panelists to give us your final messages, and you have a minute each. And I'll start with Professor Anthony Costello, the Professor of Global Health and Sustainable Development at University College of London.
Well, first to say, I'm very pleased that with your acquisition group across Africa, I see that in wealthier African states, they are obtaining bilateral agreements to get vaccines in, which will add a lot to the efforts from the COVAX initiative, which is going to be limited, to be honest. So I think Africa taking control of its own acquisition of vaccines in addition to COVAX is a very good thing. And although you are behind the curve in terms of vaccination, because you have a much younger population, a more rural population, you have had much lower death rates than other parts of the world. But we must put pressure on wealthy countries to ensure that they offer the finance and the assistance to Africa to get the required number of vaccines in, and we'll be playing our part to put that pressure on as well. Particularly as Europe and North America become vaccinated, they should be diverting their vaccines to you later in the year.
Thanks for that advocacy on our behalf. And now we go to you, Dr. Saban Nsanzimana, the Director General of Biomedical in Kigali. But now, as you give your final remarks, I will have a question for you to address during your final remarks. Are you happy with the speed of the rollout of COVAX vaccinations in Africa? And this comes from NBC News.
Great. Thank you very much. Let me first talk about three things I have been reflecting on during this conversation. Number one is to say vaccines really work. There's no way you can end a disease or a pandemic without a vaccine. And we have seen it in the past. And with COVID, it's even more clear. Number two, vaccine alone cannot finish COVID-19. So we'll need to combine vaccine plus other public health measures that we've been doing since the beginning of this pandemic, early last year, and for some continents or even before. Number three, the best way to invest in economy recovery is to get more vaccines right now. So the more we wait, the more losses we are losing in all our economies. And regardless of borders of countries, it affects everyone, everywhere. And my last, since you asked about the rollout of vaccine, I think I already talked about, we're waiting right now to get vaccines. I'd wish to get more doses more faster, and understand COVAX is a great initiative that has been really struggling to bring all these vaccines together because there have been other issues. There have been countries who want to get all doses for the total populations, while we're having people dying or affected in many places. So I'd wish to have more doses quickly. I'd wish to have more COVAX capacity getting doses to any other country that is still waiting. We are not among the countries that have not got any dose, but I understand they're feeling, their doctors who are now in frontline, what they feel. But if they can get vaccines, if we can have more additional vaccines and everyone equitably, would be great. Thank you.
Thank you very much also for that advocacy and note for equity, even when Rwanda has started, and you can take note that other countries have not started, and you also wish them to have that chance to start. So now to you, Dr. Richard Mihigo, but as you also come with your final remarks, we have two questions for you from Natalie Maura from Xinhua News Agency in Nairobi, Kenya. And these are, when do you expect to vaccinate 20% of the African population and possibly attain the herd immunity? And the second one is, do you see the continent realizing the dream of establishing a robust manufacturing capacity for vaccines, drugs anytime soon? Over to you, Dr. Mihigo.
Yeah, thank you, Dr. Fiona. Let me first really thank our three panelists today. It has been a great conversation. Thank you, Dr. Saban Nsanzimana. Thank you, Professor Costello. And thanks, Dr. Kizerbo. I think we learned a great deal from this very, very powerful panel. And I would like really to re-emphasize the need that the message that I made at the beginning of this meeting, that this is really the time where we need to build on the momentum that has been created with the first delivery of vaccines and to expand that. We have heard a lot of issue related to vaccine hesitancy, misinformation. Indeed, this is a big issue. But what we have also learned with these countries that have already started to roll out the vaccine, people are eager to get vaccinated when a vaccine is there. And we have heard it very loud and clear from our colleague from Rwanda that people need and are waiting for the vaccine. So I think this is a strong appeal to the international community to make sure that Africa is prioritized in the delivery of the vaccine, that people, front healthcare workers, those who are high risk of the vaccine, get their jab as soon as possible. The third message I would like to convey is the great news we heard from Guinea as well as from DRC. And I think this is a really a situation where we should be proud of the system that has been put in place in terms of preparing the continent to respond to pandemic or to outbreaks. We've seen the situation in Guinea where partners, WHO taking the lead, working with all the partners, supporting national government to respond to the pandemic. We can come to a very close, we can end this outbreak in a very shortest period of time. We've got the experience, we've got the tool. I think it's now time to really make sure that these all can be combined to have a successful implementation. And then finally, when it comes to the vaccine acquisition, I think Professor Kestolo, you insisted a lot on the need for diversifying the source of provision for vaccine of this region. Indeed, there is no COVAX vaccine, there is no AVAT vaccine. There is vaccines that needs to get in the arms of the people on this continent. And we are trying to really ask not only the private sector, but also other parties to support countries, to make sure that the vaccine can become available to protect as many people as possible in a shortest period of time. Now, very quickly to address this two small question of our journalists, when are we expecting to vaccinate up to 20%? I think this the plans were to at least deliver the vaccination through COVAX before the end of the year. This goal is still valid, and we are working hard to make sure that the vaccine doses are going to be delivered through the COVAX facility to reach 20% of the population before the end of the year. So it's true that we've gone through some turbulence during this first period, but we expect that as more vaccine are going to join the facility in the portfolio, as more vaccine are going to get the WHO EUL, we are going to expand the reach to the people. Now, when it comes to get the 60% or the herd immunity, that's become another story. But it's true that the combination of the efforts that are currently going on through COVAX, through the African Union-led initiative, the private sector may see the situation accelerating in the next couple of months, but we hope that by early next year, we could potentially see a herd immunity, at least 60 to 70% of the population be vaccinated in the region. And then finally, in terms of vaccine manufacturing, if we are to learn about something out of this pandemic, it's for this region to try to invest in a local capacity to produce vaccine, because we cannot wait until another pandemic to be in the same situation. So there is a lot of efforts going on through the African Union, through WHO supporting countries to try at least to establish some capacity, being for fill and finish of vaccine, but also having a robust conversation in the mid to long term on how we can establish a viable vaccine manufacturing capacity in the African region. So I thank you very much for your time. And I would like also to express the greetings from the regional director, Dr. Moeti, who is not able to join us today, but for sure we'll be with her next week. Thank you, Fiona.
Thank you very much, Richard, and thank you, our other panelists. This has been really long, and you have agreed to stay on with us and to speak to our journalists, and I hope a lot has been answered. So we now come to an end of this virtual press conference, and for our Francophone reporters, we still will have Dr. Richard Mihigo, who will stay online for just a few minutes to answer your questions. Have a very good afternoon, everybody.
To stay today for the Francophone group, so I'm really sorry about this. Yeah.
Oui, bonjour, bonjour Dr Mihigo, bonjour à nos collègues journalistes francophones. Nous avons que 4 questions aujourd'hui, 2 questions du journal Le Monde de Laurence Caramel et 2 questions de Ndeye Kadidiop de Sud Radio. Je vais commencer avec les questions dans l'ordre auquel elles sont arrivées. Donc la première question, est-ce que Madagascar a finalement commandé des vaccins via COVAX? À vous, Dr Mihigo.
Merci beaucoup. Donc, comme je le disais tout à l'heure, nous n'avons malheureusement pas beaucoup de temps. J'espère qu'on va aller très vite parce que dans 5 minutes, je dois rejoindre une autre réunion. Non, malheureusement, Madagascar n'a pas encore commandé les vaccins, mais nous avons bon espoir avec les dernières discussions en cours avec les autorités malgaches. Il y a beaucoup de discussions en cours et nous espérons que très bientôt, nous aurons des annonces de ce côté-là. Avec le pays, cette fois-ci, étant prêt de rejoindre l'initiative et de recevoir les vaccins à travers l'initiative COVAX.
Merci beaucoup. On fait vite alors, je vous le promets. Seconde question, dans combien de temps l'Afrique de l'Ouest pourra-t-elle disposer du vaccin Johnson, qui est très attendu par certaines populations qui ont peur d'autres vaccins dus à la polémique AstraZeneca?
Avant de répondre à ça, je voudrais d'abord encore une fois réassurer l'opinion et nos collègues journalistes que le vaccin AstraZeneca est un vaccin sain. Il a été notamment revu, a reçu l'autorisation d'utilisation en urgence par l'OMS et les dernières recommandations, que ce soit de l'Agence européenne des médicaments et de l'OMS, réaffirment cette sécurité de vaccin. Alors, pour ce qui est du vaccin Johnson & Johnson, comme on le sait, il a reçu déjà l'autorisation de l'OMS pour être utilisé en situation d'urgence. Mais malheureusement, la seule contrainte, c'est pour la disponibilité de ce vaccin. Pour le moment, c'est un vaccin qui est uniquement encore produit aux États-Unis et pour lequel nous n'avons pas encore de visibilité sur l'arrivée de ce vaccin au niveau de l'initiative COVAX. Il est clair que l'initiative COVAX avait déjà noué de partenariats pour acquérir ce vaccin et nous espérons que peut-être dans le 2e, voire le 3e trimestre de l'année, nous pourrons déjà avoir ce vaccin à travers l'initiative COVAX.
Merci beaucoup, Dr Mihigo. Malheureusement, comme vous l'avez dit, je ne dispose pas de temps supplémentaire. Je vais donc vous remercier et vous souhaiter une bonne semaine en espérant de vous revoir tous, amis journalistes, la semaine prochaine pour la conférence de presse. Merci beaucoup, Dr Mihigo.
Merci et toutes mes excuses encore une fois.